Thank you so much for coming out for a doc talk today. I'm so excited. This doctor needs no introduction. Most of you know her. We have the honor and privilege of having her work here at Park Royal. She has her hands in so many different things. I'm always trying to get her out because I'm just so impressed with the different procedures, the different programs that she's come up with to help patients. And today she's here to talk to us about the detox of methamphetamine, the protocol with that. So this is something that is new, and I'm personally really excited about it. And without any further ado, I will give the floor over to Damayo.
This is my first doc talk, so go easy on me, all right? So, but anyways, I always wanted to do one, but I just wasn't sure what topic. But then I went to this addiction conference held by Harvard, and they were like, "Oh, this is the first time I've ever seen an inpatient management protocol." So I was excited about it, and so I wanted to share it with you. And this is what we're going to start with. To know about how to treat it, we need to know the impact it has in our society. So we'll talk about epidemiology. And of course, we need to know how it began and who used it way back when. We need to understand the chemistry, the mechanism of action, why methamphetamine is so hard to get over the addiction. And we're going to talk about mainly intoxication from methamphetamine, which is really the biggest problem that we have to manage when these patients come in, right? So I'm going to talk a little bit of differential diagnosis of methamphetamine psychosis, because we still have to think about other underlying psychiatric issues. And then what are the risk factors why people get psychotic when they use it? Then I'm going to talk about common medications that we use. And these are like the latest data of what I found, as well as then what you're all waiting for, the protocol that Harvard has used in a study to show that what they did was actually helpful. So before we begin the talk, I want to just share with you a video about this young man in recovery, but he does such a good job at relaying the experience of psychosis that he went through with meth. So let's have a little bit of that.
So typically what it would look like when I would use meth is I knew that the next 7 to 10 days are going to be used up because I'm going to stay awake the whole time. And at that point, you can't be around other people because they'll know instantly what's going on. So I knew when I was using meth, I knew that after day 3, I had to remember that everything I was thinking was insane. I couldn't believe my thoughts because my mind would tell me crazy things. And after day, maybe into day 4, I'd start hearing the soundtrack, so you could hear music in the back of your head that would just play over and over. Like if you walk down the street and you see like those people that look homeless and they're talking or singing to themselves, they actually hear music and they hear people talking to them. So when I was walking down the street and I'd be singing a song, in my head the song was real, it was actually playing.
It's just really eye-opening to listen to a guy in recovery still managing to remember those things. Because most of the time what happens with meth, it kills the brain cells. But he was eloquent enough to relay that. And so knowing this, we get a better picture of what these patients are really going through, that we can't just dismiss them, right? So why is it we have to talk about this? This graph from 2003 to 2015, the top line is the number of hospitalizations that's related to meth. And from 2005, you see this 2008, it just jumped up. 2015, 245,000% hospitalization. It jumped up. That's more than the opioids. It only jumped up by 46%. Next thing, I want to share with you the study, methamphetamine use in psychiatric hospitalization, chemical restraint, and emergency department length of stay. This was a study in a hospital in San Francisco. They looked at all the ER visits related to psych. Almost 50% was related to methamphetamine intoxication. That's pretty significant. And they did this study from June 17 to July. It's about 1 whole year, 50%. And what they found out though, this is why methamphetamine can be dangerous, because the odds of needing chemical restraints is higher than any other substances that anybody else can drink with, and increases the length of stay in the ED. They did find out it didn't increase psychiatric inpatient admission, but it's the ER where they're causing a lot of trouble. So what do? You want to get them out, bring them here in our intake, and we have to have them, right? And we're like, what do we do? So let's talk a little bit about methamphetamine before COVID hit. That's kind of scary. Even before COVID, overdose with amphetamine tripled prior to COVID pandemic. But here, the overdose death from mainly amphetamines rose 180%, even before COVID. During COVID, this was a study by the Millennium Health Lab. I think we use that, don't we? We used to. Anyways, they do drug screens all over the country. We've used them in the past. And in the early days, they decided to look at all the drug screens, what they were positive for. So what they found was illegal use of meth grew across the country in the early days of the pandemic. It increased by 20%. So pre-COVID, January to March 12th, the day before COVID was declared an emergency. Between March and May, it jumped by 20%. Actually, the real data was 29%. So now we know all this. Now we know where we've come to. Let's talk about where it began. 1893. Did you know methamphetamine was created way back when? From ephedrine, right? Ephedrine in Japan. Crystal meth, way back when, 1919, came from ephedrine using red phosphorus and iodine and whatever else that people find in their house. This is what I like to share. World War II, we do know Hitler gave this to all his soldiers. That's why they were able to go, go, go. So they gave it all to elite forces from the tank crews and aircraft personnel. And this is just a little bit of fun. Flyers chocolate. Can anybody pronounce that? Who's German here? Well, I guess I'll try.
It's legal chocolate.
There you go.
Especially in stations in Germany.
Okay, there you go. They gave this to pilots. Anybody heard of that? Flyers chocolate. I mean, I don't know. Maybe might be a little fun to try, right? Tanker's chocolate. All right, Bill, give me that. Give me your best German.
Antipsychotic.
There you go. Given to the tank crews. Hitler. Oh, he was the biggest user. 1942 to 45, he got daily IV injections from his doctor to treat his depression and fatigue. And he did have Parkinson's, but they all thought, you know what, this depression, fatigue, and Parkinson's, probably because he was using meth way before then. So that is the history, and that is where it's come from and what it is. I didn't mention there that there are clinical indications for it. One is ADHD and obesity, and the brand name, trade name is Dexozin, We don't use it a lot, but sure, there's like all kinds of like generics out there. But so there is a clinical indication. But what they found out was he was abused a lot. So they decided, let's not promote that. This is the chemistry of methamphetamine. Here's that ring, the methyl groups on each side, and the nitrogen group. Anybody tell me what other street drug that is derived from methamphetamine? MDMA. And I'm going to talk about the difference between MDMA and methamphetamine. So that is methamphetamine in a nutshell. It's chemical makeup. This is the reason why methamphetamine is so addictive. It enhances the release of the monoamine transmitters, serotonin, dopamine, and norepinephrine. Anybody knew that it actually released serotonin? I thought it was all dopamine and norepinephrine. So going back, MDMA, ecstasy, I think that's right. It is tweaked to mainly release serotonin. That's why it's the love drug. And when you take it, you just love everybody. So that's the serotonin. How does it do this? How does it release it? All kinds of ways. And it has the most mechanism of action of all the psychostimulants, including cocaine. First of all, it releases the monoamines out of their storage into the synaptic cleft. It obstructs the reuptake. So it's kind of like an SNRI, right? It inhibits monoamine oxidase. What do we know about monoamine oxidase? MAOI inhibitors, right? So it inhibits the breakdown of the enzyme. And it enhances tyrosine hydroxylase, which is the enzyme that makes dopamine. I love this picture. This is methamphetamine. It goes into this vesicle. It increases tyrosine hydroxylase, which makes it, and it inhibits MAOI, which breaks it down. But not only that, once you force the release of it, it blocks it. So this is the reason why meth is so good for people. It attacks everywhere, prevents reuptake, prevents breakdown, and enhances the synthesis. And the one thing about meth that it is lipid soluble. As you know, our brain cells are surrounded by a lipid layer. It also crosses the blood-brain barrier quickly. And so you get this immediate effect to the brain. That's why people love it. Unfortunately, too much causes cell death and damage to the dopamine nerves. As you know, people who use a lot of psychostimulants, they wind up having movement disorders, and that's what happens. So here's a quiz. What's the most common type of meth-induced psychosis? What do you see in the psych unit? What are they saying all the time? But really the number one psychosis related to meth is paranoid delusions, normally related to ideas of references. You know, they're following me, they're after me, the TV is watching me, right? So yeah, same thing as delusions of persecution. And of course, they do hear things, see things, and they do have this enhanced sense of self. These are the ones that believe they're Superman, that can fly out a building. Or they think they're Incredible Hulk and they want to bash into things. All right. Here are the physical effects of methamphetamine. We still need to know these things. As you know, high energy, that's why it gets abused a lot. Insomnia, they cannot sleep for days. On the heart, tachycardia, arrhythmia, hypertension. But the most worrisome thing is that the overdose. Circulatory collapse, hyperthermia, seizures. And this is the most common way people have overdosed on methamphetamines that resulted in death. As you know, skin picking, dental decay. We see this a lot, when they come in. I mean, they don't even have to tell you what they're using. You already know what it is, right? Okay. What's the biggest differential diagnosis of methamphetamine psychosis? We have to know, is this schizophrenia, right? You got your hallucinations, disorganized thinking, anhedonia, flat affect, grandiose delusions, and thought insertions. All these symptoms are schizophrenia. So the trick is, how do you differentiate between that? It's all about timing. So somebody comes in, they're new. You don't know them from Adam. They're psychotic. It resolves. That's usually what? Brief psychotic disorder, right? And after 30 days, if they continue, you got your schizophreniform disorder. But once you hit that 6-month mark with psychosis, you have schizophrenia. So first onset of psychosis is hard to tell, but you have to think about that. But this is the thing that, what is the risk for people who have methamphetamine psychosis? This is fascinating because it talks about even the risk if you're related to somebody who's had methamphetamine psychosis. How many times is the risk? 1 time, 2 times, 3 times? How many times do you think it could be to develop schizophrenia if you're related to somebody with methamphetamine psychosis? 5 times more likely to have schizophrenia. So there is a correlation between people developing methamphetamine psychosis because they are more prone to psychotic symptoms. And it runs in the genetics, mainly through the DRD2 receptor, the dopamine receptor that affects the dopamine receptor that talks about psychosis. And of course, you don't know what came first, because these people who have a primary psychotic disorder, guess what? They like to use drugs. They like those amphetamines. So who is at risk for methamphetamine psychosis? If you're dependent, you have 3 times the risk of developing psychosis versus non-dependent. This is another study. They're saying 26 to 46% have dependents have methamphetamine psychosis. But other risk factors, polydrug, more drugs you take, the more that your brain is being killed. Psychiatric comorbidities. Let's think about this. What are the most common ones you think are related to people having a risk of methamphetamine psychosis? Affective disorders. That was interesting to me. I thought it was just a psychotic disorder, but no, mood disorders and antisocial personality disorder. Why do you think that is in relation to methamphetamine psychosis? How many of these people who come in drug addicted on meth, high on meth, they came from jail, they don't care about the law, they just want to get high because it feels good. All right, and of course, family psychiatric history. That's a no-brainer. So the route of administration, this is another interesting thing that I learned. Which route has a higher risk of psychosis? Smoking or injecting? Any guess? Smoking. When I put 1.7 years, that's the time it takes somebody smoking meth to develop psychosis, 1.7 years. And smoking does not protect you from developing psychosis from meth. Look at that, 4.4 years it takes for them to develop psychosis from injecting. Even though, yes, they have a greater severity of psychiatric complaints and disorders because what? Injecting is 100% goes to the brain that time versus smoking. So here's another quiz. How long does it take for the psychosis to resolve with methamphetamine-induced psychosis? The average time, though, is 1 week. So just because the patient is now no longer acting out, but 3-4 days later, you're still psychotic, you still can't think that they're schizophrenic because it can last up to a week. So the antipsychotic medications that I went ahead and researched on that had the most use or data for treating methamphetamine-induced psychosis is Haldol, right? That is like the tried and true, brings you down, hits all the receptors. Risperidone. I was like, not sure about that, but I remember in training, they always talk about risperidone is great for bringing people down. And I do know that it is indicated for people who have acting out, especially kids. So do I use it? Not really. We know about olanzapine, right? Zyprexa. We like that Zyprexa. 10 milligrams IMPO. Why is it good? It is also sedating, and because it's very antihistaminic, because that's why a lot of people don't like to take Zyprexa. When you have too much histamine and even has some serotonin in there, they like to eat, right? But it's sedating. It gets people down. And quetiapine, no injectable form, but also, I mean, if they don't have schizophrenia or psychosis, don't we normally give people Seroquel? What do we do it for? Yeah, insomnia. Yeah, because it's high in histamine. But if nothing works, this is what we do, right? Although we're not supposed to really do that. We have to pick two. That's the worst case scenario. All right, supportive meds. This is what I just found when I'm just thinking about it. What would I give to somebody who is in an agitated state from methamphetamines? As you know, it stimulates you. It's sympathetic. So trazodone makes sense because what it does, it decreases the neurotransmitters and the serotonin, norepinephrine, and all that. But we don't like to give it that much to people who are psychotic. Why? What's the side effect that you worry about with that? Nightmares, right? Because you don't want to make them think that, you know, they're even more psychotic because they have such strange, crazy dreams. Clonidine, I think you all know why. You know, that brings down the adrenaline surge as well as cortisol. So these things are all done to decrease the norepinephrine reaction that comes from being intoxicated with meth. Anyone knew anything about vitamin C in meth and why we use it? Methamphetamine is a base, and you give vitamin C, ascorbic acid. It takes it and it helps it excrete through the kidneys. So now you all know why I came to this and why we're talking about this. This is the protocol that I learned. And the funny thing is, when I was there at that lecture, I was like, hey, I used some of those things. I'm glad somebody else verified it, right? Because for me, it was just all about instinct and trying to figure out what to do with these patients. And everybody knows my cocktail: Ativan, Seroquel, Benadryl, you know? VO, schedule, don't mess it, you know, like you gotta just do that the first couple of days. So this protocol was based on, you know, all these like heads, you know, at Harvard. They studied what is it, the best practice and newest data for psychological and pharmacotherapy in order to come up with this protocol. So they collaborated with the Mass Gen Hospital Addiction, which is Harvard. I mean, this included like social workers, doctors, nurses, all kinds of things. Bay Cove staff is where they did the study, Bay Cove, which is kind of like a detox center. The Department of Public Health was involved in this. So this protocol was vetted, tried and true. They argued about it until they came up with it. And of course, they had to educate all the staff at the halfway house, like, what is methamphetamine? And it's a small trial. Yes, it is, because as far as we know, I mean, like the methamphetamine patients, they come and go in the ER, so it's hard to capture them. But so they used 23 all males. You had to do a comprehensive medical evaluation. And vital signs, gotta keep checking the heart rate. Make sure that they don't have arrhythmia, otherwise they need to go to the hospital. Pulmonary status, are they breathing okay? You know, do they have a PE? You know, these kinds of things can happen, vasoconstriction. Of course, you know, rule out, make sure their teeth are healthy, even though they don't look all that great. And the skin excoriations, gotta make sure that they don't have any other infections going on. So the initial order is what? They give vitamin C. And the dose is 1,000 milligrams twice a day for 48 hours to help excrete the methamphetamine. And this was new because I was not aware of this, and I think we should implement this because it's not about medications all the time, it's behavioral. Of course, we gotta, you know, encourage the patient to eat and drink. And if they miss meals, you hold it for them, because when they're awake and they're hungry, they're going to be irritated because they don't have food. Reduce stimulation. You know, keep them away from noise. Put them in the end of the hall, or keep the lights low. So because they're already suffering from psychosis, and then you do all this stimulation. Sometimes, you know, in that unit, it can get pretty loud. So you want to decrease the stimulation so they're not as agitated, because they're already psychotic and they're already scared and they're already. And this is interesting. You allow the patient to sleep as needed. They can skip group because they're sleeping, and they do not get kicked out in this protocol. And then, yeah, some of the things they do too, bring the meds and food to the patient, so they don't feel threatened, and shows that you do care about them. So I think you're all waiting for this, right? Pharmacologic, this is what they use. For agitation, Benadryl, 25 milligrams 4 times a day. Not even a PRN, they just gave it. But you have to hold it for disinhibition. As we know, there is such a thing as paradoxical effect. That's why if you give it to some kids, you think that you're trying to get them to sleep. What do? They get wired for sale. Exactly. But if they don't have that, you know, Benadryl is fine. 4 times a day. Not even, you know, question it, just give it to them, which I think Sarah knows. I already do it. You know, 50, except I don't do it. They're sleeping, they don't want to be bothered. So I give it 50 twice a day. And this is good. Equilibrium, scheduled. And instead of a PRN. But of course, what patient population does get disinhibited when they get a benzo? Geriatric. That's why you got to be careful. You know, when you give this to an elderly person that maybe still hooked on that. But if they're not having that, let's just give it 3 times a day. And I choose a different benzo, but I do. Sometimes I do give it 3 times a day when they're really out of control. They just need to go down. Or moderate severe agitation or paranoia or psychosis. There you go. As we discussed already, it is highly sedating, and it, because of all the histamine in there, they gave it PRN, and depends on the patient. Do we need to give it scheduled and then taper it? But if, you know, those 2 things don't work, then they add that medication. Of course, yeah, you got to call the doctor if they're really hallucinating, and you have to give Seroquel. And they chose mirtazapine to sleep. As we know, mirtazapine is sedating. And then what's the other thing that mirtazapine does?
It's you're hungry.
Yeah, you know, because they haven't eaten for a couple of days, you know. So, and the nutrition factor is very important. So the results of this, got 23 males, half of them were in the behavioral intervention only. The other half with medication and behavioral. But they didn't say which one did better, but guess what? Only 4 left early. So I would be like, do medication and behavioral because we need to do that. You know, medication needs to be there because especially when we're like dealing with people who are out of control and you don't want them, you know, destroying a unit, right, Amber? Okay, so what was the feedback from nurses? They said they like the option. Because before that, what do we do with it, right? Let them sleep it off and then, I don't know, PRN, like ETOs. So, you know, beginning to be honest about their meth use because now they have a protocol to follow. They really like the behavior component. And they like all the different meds in the protocol. And that way they learn more about what, you know, meth use is about. I said the Seroquel works the best according to the nursing feedback. Benadryl helps the clients for anxiety and they think vitamin C is helpful. And, you know, they all said maybe they can expand it to next level care. I think this protocol can be expanded to anybody like who's suffering from psychosis and getting agitated. But I wanted to share with everybody that where the thinking was why we wanted to do this. Because as we know, you never know who you get on the phone when they're agitated or not. So, and sometimes you can't even get a hold of them, right? So you might as well get orders from somebody. They say, start that protocol. Okay. So one of the things that I thought like, you know, to tie everything and what is needed in a inpatient management protocol for methamphetamine, you got to do your physical exam. You got to monitor their vital signs. Get that vitamin C in there, help excrete it. Behavior. I mean, I think this is the thing that's lacking in our protocol in what we do, because we don't know how to approach these people. And the pharmacologic, the antihistamines, I have to give in visceral sometimes, and the benzos. So Librium is fine, but I prefer lorazepam because of the fact that, you know, you can give it a shot or a pill, depending on what they need that day. And of course, the antipsychotics, olanzapine, haloperidol, and if they can feel the Seroquel. So I think that's all I got. Thank you, everybody. I appreciate y'all coming.